Boa noite a todos. É com muita alegria hoje que a gente faz o nosso Grand Round em associação com a Universidade de Duke, e nós vamos iniciar com o nosso primeiro caso da noite. Eu vou chamar a nossa residente Carolina Huang para começar, e o doutor Luiz Fernando Teixeira para discutir junto com o setor da Duke. Obrigada, Luiz. Obrigado, Carol. Vamos começar.
Can I start, Dr. Luiz?
Yes. Miguel, are you listeners?
Yes, I can hear you. And
thank you very much for your presence with us in our ground round. It's a pleasure for us to have you for this discussion. So we are going to present, and you can stop in all moments that you want to discuss or comment something. It's very important, your comments. Thank you very much.
Thank you. I'm happy to learn some oncology and Portuguese. So we'll see how it goes.
Okay. So good evening, everyone. My name is Carolina Huang. I'm a second-year resident here in the service, and today I'll present the Ocular Oncology Grand Round. My preceptor is Dr. Luiz Fernando Teixeira, and the head of the division, Dr. Melina Morales. Today's case is about a 17-year-old female patient born and raised in São Paulo and who is currently a student. This patient complains about a mild blurred vision in her right eye for the past 3 months, and due to this complaint, she went to another service to see an ophthalmologist. This ophthalmologist noted an iris lesion and an increased IOP in her right eye, but at that time decided to not start any treatment and refer this patient to our service. Her past ocular and personal history were both unremarkable, and in her familiar history, she only had a mother with glaucoma. In her ophthalmologic exam, she had a visual acuity of 20/25 in her right eye and a 20/20 vision in the left. Her pupillary reflexes were a little bit irregular in the right eye, and you see in a little bit wide, and it seemed to be normal in the left. I'll show you photos of the anterior biomicroscopy. In her right eye gonioscopy, we could see a mass from 9 to 1 o'clock with an intense pigmentation of the angle, but for sure we could see a closed angle at 6 o'clock. In her left eye, she had an open angle 360 degrees with a 2+ pigmentation. Her intraocular pressure was 17 millimeters of mercury in the right eye and 10 in the left. And in her fundus exam, we had a little bit of difficulty to examine the right eye because she had a poor mydriasis. But from what we could see from the posterior pole, she had a pink optic disc with sharp margins, a cup-to-disc ratio of 0.3, normal vessel, normal macula, and attached retina. And the fundus exam of the left eye was completely normal. Here in the anterior biomicroscopy, we could see normal eyelids and eyelashes, a clear conjunctiva and a clear cornea. These two masses temporally and superiorly with a slight brown coloration with some points of hyperpigmentation and those neovessels. This mass alters the adjacent structures, causing this dyschorrhea. And we can also see a diffuse hyperpigmentation of the iris and an anterior synechia here inferiorly. But the patient was phakic, and we could not see any signs of anterior chamber reaction. Here are some more details of those masses, superiorly and temporally. In these other photos, we can better see the diffuse hyperpigmentation of the iris and the ectropium uvei, and here inferiorly the anterior synechia. In the left eye, she had a normal exam. Just a slightly hyperemic conjunctiva temporally, but a clear cornea, trophic iris, and phakic. This just to compare, to see the heterochromia the patient presented. So for the diagnostic hypothesis, just to remember, we have a 17-year-old patient with a mild blurred vision in her right eye, presenting with that mass and a high IOP in the right eye. Our first diagnostic hypothesis is of a tumoral etiology. We don't know for sure if it's primary, like a melanoma, or secondary, like metastasis from a carcinoma or a skin melanoma, but tumor is the first hypothesis in this case. but we cannot rule out other etiologies like infections such as syphilis or tuberculosis, which are diseases that can mimic a lot of other conditions and could present with a mass in the anterior chamber like granuloma, tuberculoma, or even inflammatory diseases like juvenile granuloma or sarcoidosis. This patient had very little signs of inflammation. She had no curatic precipitate, so infection and inflammatory etiologies are less likely in this case. For the management, we decided to ask for a systemic workup, so we ordered serologies, a tuberculin skin test, complete blood count, calcium, hepatic function, urinalysis and urinary calcium, even angiotensin converting enzyme, thinking about sarcoidosis, and also a dermatology evaluation. We also asked for some imaging exams, including ultrasonography of the right eye, ultrasound biomicroscopy, a brain in orbits magnetic resonance imaging, to better understand the extension of the mass, the relation of that mass with the adjacent structures. And because we're thinking about a tumor, we also ask for an abdomen ultrasound and chest and pelvis computed tomography to assess any signs of metastasis. I'll show you some of those results. So here, the serologist for HIV and syphilis came back negative.
Carolina, can I ask you a question? Can I interrupt?
Of course.
So we have a young patient, and the first thing that comes to my mind is, do we have an older picture, regular family older picture of this girl? So what I'm trying to ask is just, I want to confirm that this is an acquired heterochromia, and she was not born with this difference in the color of the iris. So
we don't have.
Did you think about it, or was that a question?
We don't have another picture of this patient. This was the first time we saw this patient in our service, but from what the family referred, they noted some different, some alterations in her right eye for the past few years, but we do not have details and documentation of this right eye from the prior time.
It's okay. No, it's always good to, when we see a different color in the in between both eyes, is to ask the family for an older family picture. Not that I'm sure you don't have it now, but it's always it's always good to ask for that.
Of course. May I continue, Professor?
She's asking you, Luis.
No, it's you.
Oh.
Okay.
It's you, Dr. Miguel. Okay, so the tuberculin skin test was 0, and the other laboratory exams came back all within normal limits. Her dermatology evaluation was also normal. In her ultrasound biomicroscopy, we could see that she had a diffuse thickening and an increase in echogenicity of the iris from 2 to 8 o'clock, and we could also see an irregularity in its morphology. From 9 o'clock to 1 o'clock, we could see this solid lesion involving the ciliary body and extending to the iris. And the side-to-side extension of the mass was 12.84 millimeters, and the anteroposterior diameter of this mass measured at 10.27 millimeters. So we're talking about a big tumor here. In these other cuts, we can see that at 6 o'clock, she had that close angle, that anterior synechia we commented before. In her ultrasound, here we're looking at longitudinal cuts at 9, 12, and 1 o'clock. And we can see this solid mushroom-shaped lesion in the extreme anterior periphery in those meridians. Here are some other images of that same mass. Here in this axial cut, we can see this mass occupying most of the anterior segment with a subluxated lens. We also performed the Doppler ultrasound that showed us an increased vascularity of this lesion. In her brain orbits MRI, here I'm showing you cuts ponderated in T1 post-gadolinium, in which we can see this hyperintense signal of the right eye in the topography of the mass in all 3 cuts. Also, when we study the subtraction, which means we are only seeing here what captures the contrast, we can also see a hyperintense signal in the same topography. And studying the diffusion here in the right side of my presentation, we can see a diffusion restriction, which means we're facing a very cellular tumor. The rest of her imaging exams came back all normal. So at this point, we could rule out infectious causes and even sarcoidosis. Juvenile granuloma seems to be less likely, but we don't know for sure if it's tumoral or not. So we decided to do a fine needle aspiration biopsy with a 30 gauge needle and decided for transcorneal access. I'll show you the images courtesy of our pathology team. So here we have a proliferation of ovomelanic cells with melanin pigment inside of it. These cells present nuclear irregularity with granular chromatin, and some have a vesicular nucleus with proeminent nucleolus. Also, we can see numerous fusiform cells with long nucleus and evident nucleolus. So all this suggests for us an intraocular melanocytic lesion with atopy. Immunohistochemistry was also performed for this patient. AE1, AE3 is a marker for carcinomas, and it came back negative, but we also tested for a lot of other markers typical for melanomas, like S100, HMB45, Melanea, SOX10. S100 came back negative. Here, what we see in brown is normal melanin pigment, but the other markers, Melan A, HMB45, and SOX10 came back all positive. So with this result, our main diagnostic hypothesis at this time is of a uveal melanoma. So with this in hand, we have to plan the treatment for this patient. When we think about, of course.
Can I interrupt? Do you have the possibility, the university, to do some next generation sequencing? Is there anyone in the lab, in the research group that could do that? I know that it's difficult, it's challenging, but I think in a case like this, it's very important.
We have some difficulty to perform the test for NGS for these patients. Sometimes we can, in research, to ask for a test like this, but it's not usually our day-by-day test. Did you think that this NGS will help in making diagnose?
Yes, so I think that it can provide, it will help with diagnosis, it will help with prognosis. Yes. And not only that, but since it's, you said 17 years old, right?
Yes.
But also because having an intraocular melanoma, uveal melanoma at this young age, I will also ask for the blood melanoma panel to see if this patient is a germ line for one of the melanoma genes, mainly the BAP1. So this type of information, and I will be happy to help you as much as I can, you know, in you to have access to this, because it does not depend on one lab, but I'm sure that at the university, I'm sure they're doing some kind of test like this for other cancers. I'm sure you know, if I will start with someone, I will talk to the melanoma people down there and say, hey, how do you do your next generation sequencing? And if they don't know, you know, I will go with a lung cancer doctors, because this is, and again, this is an excellent example of how important this is for the diagnosis, for the prognosis, and for the patient.
Yes, I agree with you. Most for prognosis, but we have some difficulties. We sometimes you can have this doing by research, and sometimes it's more difficult. Do you think that the BAP1, I know that is not for the germline situation, but do you think that the BAP1 in immunohistochemistry helps something?
I think that
in your experience,
well, having this information, the BAP1 gene, it became key in all melanoma patients. And as I explained, I think that you can make a difference for these patients. And even if it's through research, I mean, there is enough information in the literature about this that, yes, you may start locally as research, but slowly it will become, part of the routine evaluation for these patients. And BAP1 is to start with a bad one, but you can provide a peace of mind if this patient has a different gene than BAP1. So I understand gene expression profile is challenging. I understand the DNA analysis is challenging, but even if it's through research, this will make a difference for your patients. Sorry to interrupt.
Oh, thank you.
It's great comments. Thank you. So when you think about management, especially melanoma treatment, some things come to mind, such as brachytherapy, iridociclectomy, and enucleation. But these two first alternatives do not seem to be a good idea for a patient, remembering we are not only facing a mass that occupies the ciliary body, the iris, and the anterior chamber, but also a melanoma that has a diffuse growing and extends throughout all the iris. So enucleation seems to be a best alternative here. It is a treatment that is chosen for advanced melanomas that occupy most of the intraocular structures, that have a diffuse growing, that cause severe secondary glaucoma or total retinal detachment, and that invade the optic nerve. So that's what we did. Here is the picture of the enucleated right eye. We can see the mass occupying here most of the anterior segment. It measured 22 millimeters by 3 millimeters. And in the histologic evaluation, there were no signs of angiolymphatic embolization nor extraocular extension. So we conclude here that we are in front of an uveal melanoma. It had a predominance of epithelioid cells, and the systemic workup for this patient were all negative. So this patient had a TNM staging of PT4B and 0M0, which brings us to stage 3B. Here, just to illustrate, a T4B tumor is referring to a tumor with a large tumor with more than 18 millimeters of base with any thickness, in our patient's case, with ciliary body involvement. And because our patient had no signs of lymph node involvement or metastasis, she was a 3B. This patient is currently at her 3 years follow-up in our service with no signs of local recurrency and to this day free of metastasis. Thank you very much. That's what I wanted to share with you today.
That's a great case, and I would like to emphasize that probably the primary was not the iris. Probably primary was the ciliary body. And it seems that it was at 360 degrees, and I want to, you explained that perfectly. A diffuse melanoma, it's a pattern of growth. So it grows more in terms of diameter than in thickness. And these type of tumors can present they can be masquerade. That's the right word to use that. This patient can have unilateral hypertension. They can have uveitis sign and symptoms. They can present like anything. So, and I'm glad you did the biopsy. When you were presenting the case, I was like, when is the biopsy coming? When is the biopsy coming? But it's a great case, and again, it shows that a 17-year-old can have a uveal melanoma as well. The youngest, I don't know if you remember, Luis, but the youngest, at least that I saw, was a 5-year-old kid from Mexico. And we've seen, I think that, Luis, we were together at Wills at that time. We saw an 11-year-old with 3 melanomas in one eye. So never rule out a melanoma because of age, never rule out a retinoblastoma because of age. But it's a great, well-presented teaching case. I don't know, happy to answer with your question.
Can I ask one question and one comment? This year I had a patient of 6 months of age with a huge intraocular melanoma with optic nerve extension up to the chiasma. So this is the reason that I bring this case. We need to think in uveal melanoma in kids and in young adults. I have one question for these patients. Even if we don't have the gene expression profile for this patient, we know that for the TNM, she has a high risk metastatic disease probability. Yes. And are you performing any adjuvant therapy protocol for this kind of patients at Duke?
Number one of the things that I think you can do is to check on the HLA-A02 marker on this patient, because in the case she developed metastases, you know that there is an FDA approved medicine for patients with the HLA marker. So that's number one. Number two, yes, there are some protocols, and I'm not sure this patient will fit in any one of those protocols because of the lack of the NGS situation or gene expression profile situation. It's not that there is a Duke, but Duke participates in different clinical trials with other institutions for high-risk uveal melanomas. But you need more than the epithelial cells information for these patients to be recruited for those trials. So I think this is an amazing teaching case at all levels. And I think that the case like this, and again, as much as Luis, as much as I can, I will be happy to help and support any decision about having us, even as research, the BAP1 NGS situation. Please check with your melanoma people at the university. I'm sure they're doing this.
Thank you.
Great, Luis. Thank you very much. And now we'll move on. Okay. Thank you, Frederico.
Hello. Good evening, everyone. My name is Frederico Novaes. I'm a second-year resident here at Escola Paulista de Medicina. Today, I'm going to present the last case of the night of our university, and then you guys from Duke will go on. My preceptor was Dr. Alexandre de Azevedo, and the chief of the division is Dr. Luciana Noia. The case report is about a female patient, 60 years old, from São Bernardo do Campo in the state of São Paulo, Brazil. She reported 15 days of blurred vision in the right eye and also described hemicranial headache and tinnitus. On her ophthalmological history, she was treating an infectious keratitis for 2 months in the left eye, the other eye. Her medical history had high blood pressure, rheumatoid arthritis, and previous herpes zoster virus in V1 topography. On medications, she was on moxifloxacin every 4 hours in the left eye and hydroxychloroquine and hydrochlorothiazide. Her eye exam had visual acuity with correction of counting fingers in the right eye and hand motion in the left eye, The direct reflex of the right eye was 4+ and impossible to evaluate in the left eye. I'm going to show you the photos of the anterior biomicroscopy and the fundus exam. And the intraocular pressure was 12 in the right eye, impossible to evaluate in the left eye. So here we have the anterior biomicroscopy of the right eye. We can see some normal eyelids and eyelashes, some hyperemical conjunctiva of 1+, some keratotic precipitates, posterior synechiae, and the patient here is phakic. In the detail, we can see the anterior chamber formed, some flare, and had this anterior chamber reaction of 2+. The other eye, the left eye, had this hyperemic conjunctiva of 4+ and opaque cornea with, it's hard to evaluate the anterior chamber, but we can see some hypopion here. And here we can see that the cornea is very thin at some points. The retinography of the right eye, we can see an hyperemic disc with some vessels, tortuosity of the vessels. We have also some medial opacities. It's hard to evaluate the macula, but it seems to be attached. And here there is what seems to be retinal detachment along the superior arcade, temporal superior arcade. And here the Serous retinal detachment in details. And here another 2 photos of the Serous retinal detachment. So at this point, we thought of some diagnostic hypotheses. This patient had the infectious keratitis in the left eye and agranulomatous panuveitis in the right eye. Also the Serous retinal detachment in the right eye. And we can think of maybe 2 main hypotheses here. One is the sympathetic ophthalmia, and the other one is Vogt-Koyanagi-Harada disease. So for the management, we ask for general blood tests, infectious serologies, chest X-ray, cerebrospinal.
Can I interrupt for just 1 sec?
Of course.
Yeah, it's Glenn Jaffe. I'm sorry. So for the serous retinal detachments, in addition to what you've mentioned, the things that I would usually think about are posterior scleritis, and you can also get serous detachment. We've reported it with syphilis before, and you can even get it with toxoplasmosis and idiopathic choroidal effusion syndrome. So with the inflammation, you wouldn't think of idiopathic choroidal effusion. It'd be unusual with keratotic precipitates and posterior synechiae to have posterior scleritis, but I'd at least be thinking about syphilis on top of it. You know, VKH certainly, but I would at least be thinking about syphilis also.
Limitless?
Yes. We asked for the infectious serologists, and I'm gonna show you here at this next slide the results. So the patient came with normal blood count, C-reactive protein also normal, and serologies of toxoplasmosis, syphilis, CMV negative, HIV also negative, and the tuberculin skin test was also negative. The cerebrospinal fluid test had pleocytosis, and the neurology team thought of an neuropathic headache or maybe an herpettic neuralgia. Also here we have the ultrasound of both eyes. The patient was phakic with diameter within normal limits and symmetrical in both eyes. She had a retinal detachment in both eyes and inflammatory and or hemorrhagic process in both eyes and diffuse thickening of the eye wall. So here as the main hypothesis, since we exclude the infectial hypothesis, we thought of sympathetic ophthalmia and Vogt-Koyanagi-Harada disease. And for the management, since the infectious keratitis was closed at this point, and we were in the emergency room, we opted for intravenous methylprednisolone pulse for 5 days.
And can I just ask, for the sympathetic ophthalmia, what do you think was the inciting agent or the inciting event?
Sorry, I didn't.
The event that triggered sympathetic ophthalmia.
Oh, okay. Yeah, so we think that the other eye had this ulcer, the infectious keratitis, sorry. And maybe at some point there was a perforation of this infectious keratitis, and then again a reepithelialization of this eye, and with some UV exposure that led to the sympathetic ophthalmia. And maybe this infectious keratitis was due to the herpes zoster episode that the patient had previously. So I'll continue for the follow-up of the patient. After the methylprednisolone post, the patient had a visual acuity with correction of 20/80, and before it was counting fingers on this eye. The reflex remained 4+, and the IOP still normal. Here we have the photos of the follow-up. We can see here the keratic precipitates, and there is no posterior synechiae here, but we can see a lot of pigment in the anterior lens capsule. And here the other eye with much better condition, with improvement of the conjunctival hyperemia and the corneal expat. Also here, the retinography of the right eye, we can see that now the optodisc is pink with sharp margins. We have normal vessels, some pigments in the macula, and the Serous retinal detachment has improved. So that's our case that we brought today. I would like to thank again Dr. Alexandre for his advice during this case. Don't know if you guys want to comment anything or discuss this diagnosis.
I believe Alexandre can comment on this before and he help you with some points.
That was a case we got the opportunity to follow for some time, and it was quite polemic because many people thought it would be vogued, Canagarada. Some people thought it would be sympathetic ophthalmia due to UV exposure. We didn't catch the first step, the first part of the treatment. The keratitis was not treated in our service, so there may have been a perforation with further operation due to antibiotics. And the point we would like to really focus is, as mentioned, the importance that we could rule out infectious causes, because at this point you have a planovitis in both eyes. We could documenting with the ultrasound, being able to see the Serous detachment. So either one of the two hypotheses, since we rule out the infectious disease, as we did, we could treat with methylprednisolone, and the patient had a great outcome. It was her only eye, the right eye. So it has a huge difference in her life, and I believe we could really help this patient without even knowing exactly if it was a sympathetic ophthalmia or a vulcanagerada. The patient then was referenced to follow up in uveitis sector.
So how are you planning to manage the patient long-term? Because one of the things that can happen with either sympathetic or VKH, they both are very steroid responsive initially. And often you have to start them at high dose corticosteroids and taper relatively slowly. And one of the things I like to do is to give a periocular steroid injection around the same time you start the systemic therapy, because that allows you to taper it more rapidly and get them off of the high dose of systemic steroids. But once you've done that, it's not that uncommon that the inflammation can reoccur. And so you have to monitor them relatively carefully over an extended period of time, because if they flare up again, you may end up needing to put them on immunosuppressive therapy.
Sure, it's pretty important to keep that in mind, that this patient have a chronic disease. It has to follow up for the rest of its life. If you have a sympathetic ophthalmia or a vulcanagerada, incidence of chronic problems may differ, being more common in invoked canal, that's some reference. But anyway, it will need some follow-up. Our sector is the emergency room in the Hospital São Paulo, so we do this first clinical treatments, improving the patient's sight, ruling out infections, but we do have a sector. Patient was referenced to keep the follow-up. As we don't follow up in the emergency room, I don't really keep in track of how was the late game in this case. But sure, really important to keep an eye on it and give it the full the follow-up of this case with a proper specialty.
Luis, you wanna comment on this periocular corticoid that was mentioned? Do you do that here? Yes, I think it's an idea and it's important in some cases, but I think it's need to follow the patient closely, like Alex is telling us. I think it's very important to be close with the patient. Yeah, I believe those were very interesting and important points that were bring out by everybody, and I believe do we have somebody from the uvea sector here that has followed this patient to clarify what happened? Probably not. Yeah, it's a good, very good case, very good discussion, very good points, and probably a very difficult differential diagnosis between the two conditions that were presented. And
I would like to ask for our international guests if they believe that ulceral perforation could be the trigger to this to eventual sympathetic ophthalmia in this case, or if you wouldn't believe it would be possible to be the trigger.
I think it's conceivable, but usually there's some sort of uveal dilation, and if it was just the cornea that was perforated and nothing else, that'd be pretty unusual.
Yeah.
Okay.
Luis? No, I think it's...
Another thing we thought is about the time relation between the ulcer and the following retinal Serous detachment, evoked canal or ophthalmic sympathetic. So that was another point we kept in mind in order to bring up this hypothesis also.
Okay, great case.
Thank
Ivan,
you.
we can go on, Ivan.
Yes, we can move on and go to the next cases from Duke. First one from Dr. Choi.
Yeah, I'll go ahead and give a small introduction. I'm Pratap Chawla, the program director here at Duke. I'd like to thank Dr. Tavares and Dr. Alaman for allowing us to present today. We're going to have two presentations. We actually flipped the order. Dr. Choi is going to present first, and the faculty moderator will be Dr. Rosedal. And the second one will be Dr. Peters, and I'll moderate for that one. Both Dr. Choi and Dr. Peters are senior residents, PGY4 residents. I'd like to go ahead and House, you can go ahead and get started. I think you've already got your screen up, and Julia, I think, is on the session here as well. I saw her name come across, and she's already here, so I'll let you go ahead and start.
Hello. Hi, Pratap, Dr. Chawla. It's very good to have you guys with us tonight. One more year. And since our first contact through Felipe Medeiros 3 years ago, and I think this has been a successful event for both universities. Thank you very much for coming again.
Hi, everyone. Can you all hear me?
Yes.
Perfect.
Go ahead, please.
Right. So my name is Alice Troy. I'm a PGY4 resident at Duke. Thank you, Dr. Challa, for the introduction. Thank you to the organizers for having us here tonight. I'm excited to present a case that I saw on call a couple of years ago, and I hope you all find it interesting. So this patient initially presented to the outside hospital. It was a 66-year-old male who came in with blurry vision in the left eye and headache for 1 week. His past medical history was notable for end-stage liver disease, status post a liver transplant. He had non-alcoholic steatohepatitis complicated by hepatocellular carcinoma. He also had a history of insulin-dependent type 2 diabetes with renal insufficiency. He had hypertension, hyperlipidemia, coronary artery disease, and had 2 stents placed, and he had hypothyroidism as well. In terms of his medications, he was taking mycophenolate and tacrolimus, both of which are immunosuppressive agents used for his liver transplant status. And he was on a host of other medications, including insulin, statin, aspirin as well. He had a 50-pack-year smoking history. He quit 35 years ago. And his past ocular history was notable for mild cataracts, hyperopia, PVD, and diabetes without retinopathy. So when he was initially seen at the outside hospital, his vision in the right eye was 20/20, in the left eye it was 20/70, and his pressures were elevated to 51 in his left eye, and he had a relative afferent pupillary defect. So I just want everyone to kind of be thinking about what they think could be causing this unilateral elevation in IOP, and I'll go through my differentials in a couple of slides, but as I go through the rest of my exam, just kind of be thinking about that in the back of your minds. So here's a slit lamp exam. So the right eye was pretty unremarkable. He had 2+ nuclear sclerosis. The left eye had 2+ microcystic corneal edema, likely related to the elevated IOP. He also had fine keratic precipitates, and his anterior chamber was deep and had trace to 1+ cell. He had a 2+ nuclear sclerosis in this eye as well, and the vitreous was clear. And the dilated fundus exam looked pretty unremarkable. He had healthy appearing optic nerves, his retina was flat and attached, and no lesions were noted. And so here is my non-exhaustive list of things on my differential for unilateral elevated IOP. Dr. Joanne Wen actually gave a great talk this morning about secondary opening of glaucomas, and a lot of those things are on this differential, but you want to be thinking about things like pseudoexfoliation, pigmentary glaucoma, steroid-induced neovascular angle closure glaucoma. These can all give you an IOP spike in one eye. And then more rare, but also to consider are things that can cause elevated episcleral venous pressure, trauma-related causes, ICE syndrome, and then again, rare, but just like we saw earlier tonight, intraocular tumors can give you a unilateral elevation in IOP. And then in people who don't have any history of glaucoma, you want to be thinking about infectious and inflammatory causes as well. So things like herpes, toxoplasmosis, tuberculosis, Posner-Schlossman, sarcoid, syphilis, and Fuchs heterochromic iridocyclitis. These can all give you a unilateral IOP spike. And in our patient who had keratic precipitates and some cell in his anterior chamber, perhaps these things are higher on the differential.
Alice, can I just make one
Sure.
point also, is that if I see a patient with uveitis with unilateral inflammation, and assuming they don't, without prior glaucoma history, and assuming they don't have angle closure or 360-degree posterior synechia, but they just have elevated pressure, the main ones that I think of are herpes virus, including herpes simplex zoster and Cmb, and toxoplasmosis. And the other one, Posner-Schlossman also could do that. Sarcoid, very unusual to cause primary elevation pressure unless they're associated 360 synechia or peripheral anterior synechia. Syphilis also, that would be really unusual. And so then obviously looking at the posterior segment is particularly important. I don't think I wouldn't make the diagnosis of toxoplasma elevating the pressure without having posterior segment findings, but any of the herpes virus, simplex, zoster, or Cmb could do it.
Thank you.
In the absence of posterior segment findings.
So at the outside hospital, they had initially suspected Posner-Schlossman syndrome versus uveitic glaucoma, which is very reasonable. And so they started him on Cosopt, Combigan, and Durezol BID in the left eye. And in terms of his clinical course, so he initially seemed to improve on these medications. His vision improved to 20/40, his pressures normalized. And then at about 1 week, they added Valtrex, 1 gram BID for possible herpes simplex or herpes zoster. But despite being on the Valtrex and despite being on the steroid drops, he continued to get worse. So his vision deteriorated down to count fingers at about 3 weeks. He continued to have 2+ cell in his anterior chamber. And so at this time, a dilated fundus exam was performed, and that showed these findings. And so these are optos photos of the left eye. There's some media opacity, and optos photos are not the best to look at the optic nerves, but you can see that the disc margins appear relatively sharp. And the macula looks somewhat pale. There's a little bit of whitening, maybe some edema. And then notably, the retinal arteries and veins appear sclerotic. And then throughout the retina, you can see that there's multiple scattered dot blot hemorrhages, flame hemorrhages. And of course, our attention is drawn to this lesion supratemporally, this area of retinal whitening. And then not shown on this photo because it was too far peripheral, but we saw another lesion on exam infranasally that was actually a lot bigger in size. So 2 areas that were concerning for focal retinitis. And so at this point, the patient was sent to UNC, our friendly neighbor, and that's where they had these photos taken. And we had an FA as well from UNC, and I apologize for the poor quality of the photos, but these were the only FA images that we could get on this patient. And so this is pretty striking. This is not an artifact, but you can see that there's essentially lack of filling in all arterial phases, truncated arteries and veins, and just really severe non-perfusion in the macula and the periphery. And so these findings were concerning for a central retinal artery occlusion and or an occlusive vasculitis. So at this point, the patient was sent to Duke after getting some initial workup done at UNC. And so just a quick summary of his clinical course so far. So he had presented initially with an acute unilateral elevation in IOP with mild anterior chamber inflammation. He was treated with topical steroids, topical IOP lowering medications, and Valtrex. But 3 weeks later, on fundus exam, he was found to have a necrotizing retinitis and a retinal vascular occlusion as well. And it was unclear whether this vascular occlusion was due to an occlusive vasculitis as part of this, like an acute retinal necrosis picture, or whether there was a separate vascular process going on, such as a CRAO, given his risk factors, and we couldn't rule out that possibility. So, so when we saw the patient at Duke, the things that were highest on our differentials were the viral retinitis, so herpes, VZV, CMV. So we decided to do a tap and inject. We sent, we got an AC tap and sent the samples for HSV, VZV, and CMV. And at UNC, they had also done an AC tap and sent a sample for toxo as well. We also decided to give him an intravitreal injection of foscarnet and clindamycin. The foscarnet was to cover for the herpes viruses, and the clindamycin was to cover for toxoplasmosis. We sent some infectious labs and recommended admission for IV acyclovir and a stroke workup. In terms of the eye drops, he was on Pred Forte 6 times a day, Cosopt, Vigamox, and erythromycin ointment. And then we saw the patient the next day in retina clinic, and his vision was hand motion, pressure was 24.
Can I just make one other comment related to the previous slide?
Sure. Mm-hmm.
So just to mention some nomenclature, but assuming the patient had some vitreous cells, if by definition, if they have peripheral retinitis, vasculitis, and vitritis, that defines the acute retinal necrosis syndrome. People always think of it as caused by herpes simplex and zoster, and that is most common, but it can also, that appearance can also occur with CMV and toxoplasmosis, and you can't necessarily differentiate them based on the appearance, except that that sort of clay pipe arterioles in general is more common with herpetic infection and possibly CMV. But that appearance of the arteriolar whitening, which is what you saw, number one would be uncommon with the central retinal artery occlusion, and number two would also be less common with toxoplasmosis, which tends to cause little plaques on the arterioles that are called Kyrilles plaques.
What role would you think an MRI would play in this patient that has such severe retinitis to rule out a neuroretinitis?
I'm sorry, Pratap, say that again.
At what point would you consider doing an MRI for a patient that presents with a retinitis to rule out a neuroretinitis, involvement of brain as well?
Yeah, if the patient, certainly if they had any neurological symptoms, I would do that. With this appearance, this is not so atypical for a viral retinitis that I think it's critical to do that at this point. I probably wouldn't have done it right away.
So when we saw the patient the next day in retina clinic, his exam was pretty stable. He had continued to have the 2 areas of focal retinitis. And so we continued the IV acyclovir, and we also decided to add on oral atovaquone to cover for toxoplasmosis, even though that was lower on our differential, since the toxo can masquerade as a viral retinitis.
And I would also point out that the toxo, doing an AC tap for toxo, which is what was done at University of North Carolina, is not the best way to diagnose toxoplasmosis. So it's much less likely to be positive than an anterior chamber tap for herpetic infection. And the serology for toxo is actually quite good. And if depending on where you send it, and if the serology for toxoplasmosis was negative, it's almost certainly not toxoplasmosis. And if you were really concerned about toxo, you should do a vitreous biopsy.
Okay. So it took a few days for the infectious labs to come back, but they finally came back, and the aqueous samples were positive for CMV, negative for HSV, VZV, and toxoplasma. The serum samples were positive for toxoplasma IgG, but negative for IgM, suggesting that the patient was exposed to toxoplasma sometime in the past, but not recently. HIV, syphilis, TB were all negative. His CMV DNA PCR was also negative. So, at this point, now that the CMV has come back positive, we have an explanation for the necrotizing retinitis, the infectious part. But what about the vascular component? Does the CMV explain that as well, or should we be looking for something else? And we felt that, yes, the CMV can certainly explain the vascular occlusion. Like we mentioned, it can give you an occlusive vasculitis, but given his significant vascular risk factors, remember that he had 2 stents placed in his heart, we felt that it was necessary to pursue further workup to rule out an embolic event that could potentially be life-threatening for the patient. And so we decided to get some labs for the stroke workup. These were all negative except for the high triglycerides, as we expected. We also got some imaging. The MRI brain showed some chronic microvascular ischemic changes, chronic microhemorrhage, but thankfully no acute abnormality was seen. And on carotid ultrasound, there was no significant stenosis. The echocardiogram was normal as well. So our final diagnosis was an acute retinal necrosis from CMV retinitis in the setting of immunosuppression with a central retinal artery occlusion in the left eye. So once we found out he was CMV positive, we switched him from IV acyclovir to ganciclovir, which has additional coverage for CMV. And I just wanted to show you kind of the progression on the treatment. So on day 3, hazy view, as it's likely just from the ocular surface, but you can see that the vision's stable, pressure is 17. He's now got mostly pigmented cell in his AC, some trace vitreous haze. On day 6, the view is cleared up a lot, and you can see that the vessels are attenuated and sclerotic. There's some flame heme around the arcades. And then importantly, the the retinitis seemed to be regressing pretty nicely. So compared to when he initially presented to day 6 of treatment, the retinal lesions have regressed quite a bit. And then here intranasally, you can see this area that I was talking about earlier, and that seems to be resolving as well. And this is just an OCT through the fovea showing some hyperreflectivity and interretinal thickening and some thinning temporally, all consistent with the diagnosis of CRAO. And on further follow-up, 6 weeks later, he did develop a new vitreous hemorrhage, likely related to secondary neovascularization from the CRAO. His vision was stable at count fingers, and so we decided to watch it and not intervene. Unfortunately, his retina didn't quite recover from all that's happened. And so 8 months later, on the B scan, there's some thickened posterior hyaloid, macular traction and thickening, and his vision was NLP. But thankfully, in his other eye, he's doing quite well. His vision is 20/20, and he had no involvement of CMV in his better seeing eye. So just a quick review of Cmb retinitis. As we all know, it tends to happen in immunocompromised hosts, so people with HIV/AIDS with CD4 count less than 50, or those who are iatrogenically immunosuppressed, like in our patient. There's 3 different kinds of types of Cmb retinitis. There's a fulminant form where you have these prominent hemorrhagic necrosis over these white retinal lesions. There's the granular form, which is what our patient had, and here the retinitis tends to happen in the periphery, and the active retinitis progresses from the borders of the lesion. And then there's the perivascular form, also known as the frosted branch angiitis, where you have these white retinal lesions along the retinal vessels. And also important to remember that rhegmatogenous retinal detachment can occur pretty frequently in about 1/3 of patients when over 25% of the retina is involved. So this is something to look out for as a sequelae of Cmb retinitis. And treatment is with high-dose induction with IV ganciclovir or foscarnet for 2 weeks, followed by low-dose maintenance therapy with oral valganciclovir. We do this until the retinitis is consolidated and immune reconstitution is achieved. Also important to know that a significant side effect of the ganciclovir is myelosuppression. So these patients should be getting regular labs, including CBCs. We can also treat with intravitreal ganciclovir or foscarnet like we did in our patient. But intravitreal therapy alone doesn't treat systemic CMV, it doesn't treat the fellow eye. So generally, if we do intravitreal, it's also recommended that we treat them with systemic therapy. So, I thought that our patient was pretty interesting because not only did he have the classic findings of an acute retinal necrosis, he also had a CRAO. And although peripheral occlusive vasculitis is a hallmark of ARN, CRAO has rarely been reported. So I found this small case series by Stephen Ye that looked at 3 patients. All 3 of them were elderly, and 2 of them had pre-existing cardiovascular disease. And so that may have predisposed them to getting the central retinal vascular occlusion. 2 of these patients had VZV and 1 had HSV. And so what about CMV retinitis? There's another retrospective study that I found that actually shows that CRAO and BRAO in CMV retinitis happened pretty not infrequently. And so about 25% of elderly immunocompromised patients, like our patient, developed a CRAO or BRAO from CMV retinitis. And they found that compared to patients with HIV, elderly patients were more likely to have occlusive events, more likely to have neovascularization or hemorrhage, and underlying vasculopathy. And they postulated that this high frequency of secondary neovascularization could be due to progressive non-perfusion and incremental closure of the total retinal circulation. Whereas in a CRAO from an embolic event, for example, the occlusion happens pretty instantaneously. And so I thought that was an interesting distinction between these two disease processes. So kind of putting everything together, our patient, looking back on it, sort of had all the classic findings of Cmb retinitis. He was an immunocompromised host. He presented with a unilateral elevated IOP, had anterior uveitis, necrotizing retinitis, retinal vascular occlusion, and then ultimately developed a vitreous hemorrhage as well. And so, when we see this constellation of findings, think of Cmb retinitis. And with that, just wanted to thank Dr. Rosedal for her tremendous help in putting this talk together, Dr. Jaffe for his expertise and for taking care of this patient in his clinic, and Dr. Sophie Kai, who was a previous retina fellow, helped take care of this patient on call and also taught me a lot about this case. So thank you. As you can hear my references, I'm happy to take any questions and open up for discussion.
I'd just say one of the things that's kind of a challenging clinical question is what to do in the long term, because usually we see people who are immunosuppressed, either we used to see them from HIV, and bone marrow suppression for transplant patients is another reason. In this patient, he has multiple reasons for being immunosuppressed, and most of those reasons are going to be ongoing because he's on two different immunosuppressive drugs. He's diabetic, and so he will be functionally immunocompromised chronically, and so his other eye is definitely at risk. We're not treating systemically the CMV, which is the source of the infection. And so when we used to treat patients with HIV, we always would treat systemically and then treat intravitreally as well. In those days, we used to have a sustained drug delivery implant we could put in, which we don't have access to anymore. But it is a question going forward, how are you going to protect this other eye? And it'll be tough to have him on chronic anti-CMV therapy to prevent it without causing bone marrow suppression. And so his other eye is going to need follow-up on an ongoing basis.
So Glenn, if you'd have caught this guy at 2040, could we have done a better job?
Yes. Yeah, I'm sure you could have. I mean, if you jump on it right away, I would have given intravitreal injection along with the systemic treatment. And just a point about the biopsy, the time that you want to do a biopsy, whether it's a vitreous, particularly a vitreous biopsy, an aqueous tap is pretty easy no matter what. But if you're thinking of something like toxoplasmosis, like we were talking about, an aqueous tap isn't going to be enough. So if they don't respond right away to empirical therapy, in this case, the empirical therapy was covering him for toxo and for herpes virus. If he didn't respond right away, that's the time that you go in. If you're suspecting infection, you suspect cancer, that's the time you go in to do a diagnostic vitrectomy. And fortunately, he responded pretty quickly, but my threshold for doing a diagnostic vitrectomy would be pretty low.
Glenn, so over the course of 8 months, he went from count fingers to NLP. What do you think was the cause of that?
That I'm not sure. I mean, normally if somebody, it's unusual to be NLP just from a CRIO, and usually there's choroidal infarction as well to an ophthalmic artery occlusion or something. And so my guess is he must have had progressive ischemia, assuming that the infection was controlled.
And is there any role for like hyperbaric oxygen therapy with these arterial occlusions?
I've never done it in the setting of an infection, although I suppose there's some rationale. We have done them in cases of CRAO just if there's nothing else that we have to do, but the results are pretty variable.
That's a great classic case. Luis, Melina, you guys would like to comment on that? It's your evening, Luis. Retina and tumor and uveitis.
It is a great case, and I only will make a comment that in an immunosuppression patient with this presentation, we sometimes can have a presentation of retinal primary lymphoma And so sometimes when you don't have response with the systemic for infection, systemic treatment for infection, you need to think in primary vitreoretinal lymphoma too. And sometimes in patients with immunosuppression that we follow in oncology, sometimes they have 2 agents for infection in the same eye, like you showed for us that you investigated. We had a patient with CMV and herpes in the same vitreal step, causing the necrosis and the vasculitis in the eye of the child with leukemia. So
yeah, I think those are really good points. In the AIDS era, we used to very frequently see multiple infections. I saw a patient with toxoplasmosis with a viral infection and a fungal infection all at the same time. And the masquerade syndrome also is important. I have a very interesting case. It looks almost exactly like Cmb retinitis that turned out to be a lymphoma. And so I think that's a really good point.
Congratulations for the case and all you did for the patient.
I have a very little question to Dr. Choi. The initial management of the glaucoma was with both COSOPT and Convigan.
Yes, that was probably a little bit redundant.
Yes, tem alguém com o microfone aberto, gente? I was just asking to close the microphone. Sorry, Dr. Choi.
Oh, yes, I was just saying that, yeah, I agree. That was probably a little bit redundant. Probably didn't need both of those combination drops.
Okay. Thanks. Congrats.
Thank you. Wonderful case, Alice, Dr. Choi. I'd like to go ahead and invite Dr. Peters to share her screen, and she'll present our second case today. Dr. Peters is also a senior resident, PGY4 resident, and she'll present a case entitled Double Trouble.
Yes, thank you so much. Can everybody hear me and see my screen okay?
Yeah, that's fine.
Thank you. So yes, thank you, Dr. Challa. Thank you, everyone, for having me. Again, I'm Catherine Peters. I'm one of the PGY4 residents. Yes, my case is entitled Double Trouble. So starting off with the case presentation, this was a 51-year-old gentleman who presented to the emergency department with acute vision loss in the left eye. He describes the pattern of vision loss as, quote, black spray paint in his vision that started about 3 days ago, but has since worsened to near total vision loss. And so now he tells us he can only see light. When we ask him about a review of systems, he describes 4 months of severe headaches. These were recently worked up by neurology, who ultimately gave him a diagnosis of cluster headaches. He also endorses intermittent subjective fevers, fatigue, and malaise over the past 3 weeks, and also has actually lost 20 pounds unintentionally in the past 3 months. He has no past ocular history. His past medical history is notable for Crohn's disease. He was on Humira, but unfortunately lost coverage in his insurance, and he had been off of his treatment for the past 6 months. So moving on to his exam, his visual acuity was 20/20 in the right eye, only light perception in the left eye. His intraocular pressure was normal at 11 and 7. Pupil exam revealed a dense relative afferent pupillary defect in that left eye. Extraocular movements were full. Confrontation visual fields just showed this generalized depression in the left. On color vision exam, he was able to correctly identify 10 out of 10 Ishihara plates in the right eye. So moving on to the slit lamp exam, overall, his exam was unremarkable in the right eye, but in the left affected eye, he had 1+ diffuse conjunctival injection. He also had 1 to 2+ anterior chamber cell. He had a minimally reactive pupil, and he had trace anterior vitreous cell in the left eye. So here is a photo of his fundus exam, which I think was quite remarkable. So starting with the right eye, this is a color fundus photo. We can see severe optic disc swelling. You see obscuration of some of the large vessels on the disc. This is consistent with grade 4 edema. You also see splinter hemorrhages here and cotton wool spots along the rim as well. Then moving on to the left eye, you see, first of all, the media looks a little hazy. You see very severe optic disc edema, complete obliteration of all of the vessels on the disc. This is consistent with grade 5 edema. You also see these dilated and tortuous retinal veins and this countless retinal hemorrhages all throughout the posterior pole and through the periphery. I'll also add that there was no peripheral retinitis on scleral depressed exam on either eye. So this finding of this innumerable hemorrhages, dilated tortuous veins, optic disc edema was suggestive to us of a central retinal vein occlusion. So for acute workup in the ED, he underwent a lumbar puncture, which did reveal an elevated opening pressure of 37. CSF fluid studies were overall unremarkable. He had normal cell counts, normal protein, normal glucose, and then we also sent off for culture and cytology. So I'll stop here. At this point, we have a patient with true papilledema, bilateral optic disc edema, and true elevated intracranial pressure. So thinking up through the differential includes intracranial mass, meningitis, malignant hypertension, venous sinus thrombosis, idiopathic intracranial hypertension, and then medication side effects. So our workup was tailored to rule in and out these specific causes. So first of all, the patient underwent MRI and MRV of the brain and orbits, really just showed findings consistent with papilledema. So dilation of the left greater than right optic nerve sheath, focal concavity of the left optic disc. And then also, looking at the MRV, it showed no venous thrombosis or evidence of stenosis. They did note this filling defect on the right, but they thought that that represented an arachnoid granulation. So overall, just showing findings consistent with papilledema and no venous sinus thrombosis. So moving on in the ED, he was normotensive, ruling out malignant hypertension. It did have a leukocytosis mildly elevated at 10.5 and ESR mildly elevated at 34. So we did send off additional lab workup, just looking for other infectious or inflammatory causes that could cause this presentation. So things like Bartonella, Lyme, syphilis, IgG subclasses, sarcoid, TB, and toxoplasma. And then in the interim, we started him on 1,000 milligrams twice a day of Diamox or acetazolamide. So the next day we saw him in clinic and we performed a Fluorescein Angiogram, which I'll show the video here. We'll just give it a few seconds to play. First, I'll bring your attention to the timing. Here, already 30 seconds have passed and we're only just now starting to see choroidal filling. So definite delayed choroidal filling. And then as more time passes, we're starting to see here this perfusion of the cilioretinal artery, but really this is the only thing that's perfused. No other retinal arteries are showing perfusion. So this was consistent with the CRAO as well.
Catherine, I want to point out, you gave him 1,000 milligrams of Diamox BID.
Mm-hmm.
That was primarily to treat the elevated ICP.
Exactly.
Mm-hmm. Just to clarify for the audience. Yeah.
Here, just showing late images of both eyes of the FA. So right eye, again, showing the disc edema, which we knew was there. Left eye, again, perfused cilioretinal artery, otherwise non-perfusion, all these retinal hemorrhages we've seen previously. So kind of putting it all together, this patient has severe true papilledema, true elevated intracranial pressure, and bilateral optic disc edema. Also has a CRAO as well as a CRVO of the left eye and delayed choroidal filling. Also, he had anterior chamber cell, which we weren't sure, was that from just the eye overall being ischemic, or is there some primary inflammatory cause that's causing this anterior chamber cell? So for the next steps, given the delayed choroidal filling, given that there was a possible ophthalmic artery occlusion, we sent the patient urgently for a CTA head and neck, but thankfully that was unremarkable, no large vessel occlusion, no stenosis. We also sent the patient off for blood work to rule out any hypercoagulability or hyperviscosity syndrome. Also came back all normal.
CTA is a CT angiogram.
Thank you. Yes, thank you, Dr. Challa. So the patient was seen by neurology and rheumatology. The patient underwent a CT venogram of the head. Repeat LP, looking specifically at flow cytometry, looking for a perineoplastic panel. Thankfully, all that was unremarkable. Patient also underwent a PET CT, evaluating for lymphoma or malignancy. Again, thankfully, unremarkable. But when we look here at a slice of the CT venogram of the head, I'll bring your attention here. This is the transverse sinus of the right side. You can see this filling defect here, asymmetric from the other side. This is suggestive of a venous sinus thrombosis. If you'll remember, the MRV originally called that filling defect an arachnoid granulation, but here on the CTV head, it seemed more clear that it was a venous sinus thrombosis. So the patient was started on Lovenox and was also started on prednisone per neurology and rheumatology to treat the venous sinus thrombosis. But interestingly, on follow-up, the patient underwent a repeat FA, which here again showing the right eye, the previously less affected eye, showing peripheral retinal vasculitis, and then a few weeks later, peripheral non-perfusion. So I'll say, I will admit that I purposefully left out some key additional history that the patient provided just to avoid giving away the diagnosis too early so that you can sort of think through it as we were going along. But the patient did tell us that he had oral and genital ulcers, which were worsening for the past month, and that he also had erythematous skin nodules on the extremities. So we overall gave him a unifying diagnosis of Behçet's disease. I'll take just a few quick moments here to go over a few things. So first, the differential for retinal vasculitis. We really like to split it up into whether the arteries are predominantly involved or whether the veins are, or both. And so some of the diseases that can affect predominantly the retinal arteries are things like lupus, polyarteritis nodosa, syphilis, ARN, Churg-Strauss, and frosted branch angioitis. Things that predominantly affect the veins are things like sarcoid, toxoplasma, HIV, and Eales disease. And then when both arteries and veins are involved, we think of things like Behçet's, MS, and granulomatosis with polyangiitis. So going into Behçet's disease, this is a rare autoimmune systemic inflammatory disease. It does cause a systemic occlusive vasculitis affecting both arteries and veins, as I mentioned. The clinical triad is consists of oral aphthous ulcers, genital ulcers, uveitis, but patients can also have skin lesions, things like erythema nodosum. They can have other papulopustular rashes. Also, they can have CNS involvement and GI involvement, as well as venous thromboembolism and aneurysms. And of course, Behçet's is strongly associated with HLA-B51.
Catherine, can I just make
yeah, please.
On that Venn diagram you showed,
Yeah.
I probably wouldn't have put toxoplasmosis on the predominant phlebitis. That's actually predominantly arteritis.
Okay, thank you.
HIV can give microvasculopathy that can be of either one.
Thank you. Yes, I will change this. So going just a little bit more in depth about ocular involvement in Behçet's disease. So about 50% of patients with Behçet's will have at least some ocular involvement, and about 80% of those patients will have bilateral involvement. Usually it starts as a non-granulomatous anterior uveitis that may have a hypopyon, but it evolves into a chronic relapsing bilateral panuveitis. So going back to our case, this patient, unfortunately, his papilledema was refractory to medical therapy, and so he did have to undergo a VP shunt placement, but thankfully this did lead to resolution of his papilledema. He was started on infliximab with rheumatology, and we are closely monitoring him for neovascularization of the left eye.
I would say this is a pretty atypical presentation of Behçet's from a retina perspective. Most commonly, you get these little white focal infiltrates that can be distinguished from cotton wool spots because the cotton wool spots usually run perpendicular to the nerve fiber layer, whereas these are just sort of round white infiltrates. They look somewhat like what you can see in syphilis, but this appearance with the papilledema and the vein occlusion, artery occlusion is certainly not the most common presentation.
Mm-hmm. Thank you. So these are just the most recent fundus photos of both eyes. These are Optos images, so it's not a true color fundus photo, but even so, you can still clearly tell severe optic atrophy in this left eye. You can see sclerotic vessels and this pigmented macular scar. So the patient now is hand motion in the left eye, thankfully still 20/20 in the right. He has had resolution of his papilledema after the VP shunt was placed. He has no neovascularization in the left eye thus far. and then has improvement and decreasing size of his venous sinus thrombosis, and then no new CNS inflammatory lesions on his MRI or MRV. So here are my references. Thank you so much for having me, and I can open it up to discussion as well.
I just mentioned this is also the kind of situation where you're going to have to follow them chronically, because patients who have neurobichettes can have a very chronic course, and the neurological symptoms will resolve, stay away for a while, and they can come back again, and sometimes you have to be aggressive with immunosuppressive therapy.
Mm-hmm.
And I may have said this the first time I saw this case, but the delay in getting a VP shunt or LP shunt in there, I think, was fortunately not consequential. But when you see one eye blown out and the other one getting ready to blow, once it goes south, it usually doesn't come back. And so this was one where, while you were doing the workup, even though you didn't understand what was causing the pressure, going ahead and doing an emergency shunt of some type to get the pressure down before things went south would have been important.
Absolutely.
Catherine, great case. So how was the diagnosis of Crohn's made? Did the patient have both?
That's a great question, and that is the question. So he did not have a biopsy, did not have undergo any endoscopy or anything, and so so it very well may be that he never had Crohn's and it was all Behçet's the whole time.
Good case.
Yeah, great presentation. Any other thoughts or comments?
Dr. Marinho, Dr. Luis, any comments? Another great case.
Hi, can you hear me?
Hi, Paula. Yes, Paula is from our Uvite's team. Welcome.
Thank you. Well, first of all, both cases were great cases, and I think that this last case, the most important thing we can take, besides the whole clinical and the atypical aspect of the presentation, is the importance that we have to give to take a full clinical inquiry from the patient to ask for other symptoms. Like when she was presenting, she gave us that she has hidden the oral ulcers and the skin nodules, which would be a perfect match to BCs. But I think the most important thing on this case is that we do have the classical clinical signs, but sometimes we have to step back and look again at the picture and think again. And one small question gave us all the answers. So I'm sorry to say, but the best cases are, as always, are from uveitis. We have enough to talk about it.
I'd like to comment, Ivan, that the use of infliximab and adalimumab can cause tuberculosis. So the patient use it biologic. So
yes,
we have to think about tuberculosis in patient with adalimumab and infliximab.
In Brazil, that would be a question where you go for the interferon gamma assay for the IgA and the quantiferon, because it's endemic for us. So this probably would have gone through treatment, or at least through prophylactic treatment, thinking about our reality. I don't think it would be pretty much the same in the US, but I would say that Brazil and India, we would have to put the tuberculosis first site. I would totally agree with you, Dr. Nilba.
Luis, any comments?
No, it's only, again, a great case. And when you showed the CSF results, you showed that the pressure was high, the measurement of the pressure. So something was wrong with the brain. So we could talk about the mass, but you could talk about the venous drainage. Yes, so this is very important. And it's an acute case, so you need to intervene quickly for this patient because it's a severe disease. This
thank you all so much for your comments. Very, very enlightening.
Thank you. Dr. Chala.
Yeah, thank you. Wonderful case presentations, also the ones prior to ours as well. Everybody did a great job tonight. So once again, I'd like to thank Dr. Tavares and Dr. Alaman for allowing us to join you today, and look forward to future grand rounds as well.
Yes, thank you very much. It was another very good evening. Nilva.
Thank you. Great night, great cases. Thank you very much for all to participate with us. And we hope to have you guys with us next year. Okay, Ivan?
Yes, for sure.
Yeah, we look forward to it. Thanks.
And you try to bring Felipe to discuss a case of glaucoma.
I have to give him a hard time. I don't know why he's not here. We'll find out.
Okay. Okay. Thank you. Have a good night.
Good night. Thanks.
Bye-bye. Thank you.